Thank you. So my name is Linda Shakad-Berbari. I'm a consultant with the Emergency Nutrition Network and currently the facilitator of the IFE Core Group. I'm very happy to be joining you for this really exciting Sharing and Learning Cafe. It's really the third and the last of a series of cafes that we've been implementing in 2021. Today's Sharing and Learning Cafe is brought to you through a joint initiative between the IFE Core Group and the Nutrition Information System, a global thematic working group, part of the Global Nutrition Cluster Technical Alliance, as well as, of course, UNICEF, WHO, CDC, and the SMART Initiative. Next, please. A reminder of the working group, the webinar working group members. Thanks to their support, we're able to implement these webinars. And of course, we're grateful to the generous support of our donors, including USAID, IRISH-AID, and UNICEF. Next, please. So today's Sharing and Learning Cafe, again, as for all the Sharing and Learning Cafes, it is really a space for us to share lessons learned and information. And for today, the objective is really for us to disseminate the findings and recommendations of the IYCF-E assessment mapping exercise. Also, to raise awareness and really discuss the updated WHO UNICEF IYCF indicators in the context of emergencies and discuss opportunities, challenges, and best practices for using these indicators in emergency contexts. As mentioned, this is a joint initiative between the IFE Core Group, the NIS Working Group, UNICEF, WHO, CDC, and the SMART Initiative. Next, please. So as we are starting with a brief introduction, we will then hand over and listen to an exciting presentation on a mapping of IYCF-E assessment methodologies. We will then move to a very exciting panel discussion to discuss the IYCF indicators, then move to a Q&A to which we encourage you to really positively engage, and then a closing. I'd like to remind you to please add your questions to the Q&A box and any comments in the chat box. Next, please. So today's facilitators and presenters, we do have a panel, and we will introduce the panel, of course, in a bit. But just to see here, I've already introduced myself, also colleagues from ACF, Hassan Ali Ahmad, Associate Director of Nutrition and Lead for SMART Initiative. Jana Daher, we'll hear from her in a bit. Ms. Fatmata Fatima Sase, Nutrition Specialist from UNICEF, and Alessandro Yalamo from FHI 360, and Deborah Wilson from WFP. Thanks in advance for your support, as well as the support of the interpreters and the other IFE Core Group webinar member working groups. And now, without further ado, I am happy to introduce to you Jana Daher, who is a SMART Project Manager, Research, Innovation, and Technology from Action Against Hunger, Canada. And Jana will start with a presentation on the mapping of current practices related to the IYCF assessment methodology in humanitarian and fragile environments. The floor is yours, Jana.
Thank you, Linda. Thanks, Linda. Good morning, good afternoon, everyone. My name is Jana, and I am going to present, as Linda mentioned, the outcome of an IYCF assessment mapping exercise that was conducted earlier this year between February and March. Next, please. The overall objective of the exercise was to map the current IYCF assessment methodology practices that we have in humanitarian and fragile environments, and specifically focusing on identifying the different methodologies used, the tools, the ways of dissemination, the challenges and the indicators that are used in these assessments, but also to understand the representativeness of these IYCF assessments in terms of sampling methodologies. And finally, of course, to analyze the data and provide recommendations to the Global Nutrition Information System Working Group and the Infant Feeding and Emergency Core Group. Next, please. So for the methodology, we had an online survey that was developed with a list of questions that we reviewed, and it was validated by the NIS working group and the IFE Core Group. Next, please. So this exercise targeted both country level and global level stakeholders. So at country level, nutrition clusters and sector partners, specifically the NIS and IYCF technical working group members were considered, and at the global level, the IFE and the GNC members were targeted. Next, please. So in terms of the results, we're not going to dig deep here, so we're just going to have an overview of the results. In total, we received 146 responses, and 88 of which they had previously implemented an IYCF assessment. These 88 responses, they came from a diverse list of countries. We have 26 different countries, and with most responses coming from Yemen and Somalia. And the majority of respondents were affiliated to INGOs and, interestingly, local NGOs and UN agencies, with only 3 submissions. I had to say this, we're a bit disappointed with the 3 submissions, only 3 submissions coming from government agencies. Next, please. So in terms of the type of assessments used to collect IYCF information, it was found that the majority were integrated assessments like SMART and food security assessments, with a small number, only a small number of standalone IYCF assessments. And when we focus on integrated assessments, IYCF data was mostly integrated into health, nutrition, and WASH assessments in that order. Next, please. So partner reported using 15 different methodologies to collect IYCF data. That was a surprising kind of outcome of this exercise. 15 is a lot, with the top 3 being CAP, the qualitative assessments, such as the focus group discussions, and SMART methodologies, so SMART surveys. Next, please. Partners also reported the inclusion of both core and optional indicators for IYCF, but let's note here that at the time of this exercise, the new WHO indicators were not yet released. Hence, you're seeing a separation of core and optional indicators here. But overall, breastfeeding indicators were the most commonly included in surveys, followed by the introduction to solid, semi-solid, and soft foods. Next, please. UNICEF and WHO were reported to be the main sources of reference for IYCF indicators used in the assessments, and they guided the development of the questionnaires. But despite having the global reference, it was interesting to note that a number of partners still reported to have formulated their own questions, and potentially this is to align to their respective programs and organizational priorities. Next, please. So the survey findings also showed that partners mainly used Excel and the ENA software that we have in SMART for sample size calculation. In addition, there was a varied approach for these calculations and the parameters used. So everyone used different types of parameters and types of calculations. And we also noted that in some cases, non-IYCF parameters, such as GAM prevalence, were used in the sample size calculation. And this, from an epidemiology point of view, it limits the representativeness of the IYCF related results. But this was not very shocking after seeing that a lot of the users or a lot of the responders were using the ENA software, which provides this type of sample size calculation. Next, please. So in terms of the data collection tools, half of the assessments were reported to be conducted using paper-based questionnaires. So this is, of course, very manual, and we all know that this approach introduces a lot of risks in human errors, but also makes the surveys usually very cumbersome. Next, please. So IYCF assessments were also reported to be mainly used. This is for in terms of how they're being used. They're used to for program purposes, specifically to establish like a baseline, evaluate the outcome of a project, and to inform proposal writing. But on the other hand, IYCF data is still not being very optimally used to inform the HNO, HRP processes, which may be attributed, we don't know, but we may be attributed to the lack of standard thresholds to interpret the severity of IYCF results. Next, please. So in terms of the challenges, a number was identified. We put a few on the slides, and they're mostly related to the lack of standardization and harmonization of methods for IYCF assessments, but also the lack of globally recognized thresholds for indicators. And in fact, the continued integration of IYCF indicators and other assessments was still identified as a challenge in terms of getting representative results. Next, please. So coming to the recommendation section, and this is just to note that we have a long list and we are providing two on this slide. But in terms of the methodology and the sample size calculation, it would be important for WHO and UNICEF and other global stakeholders to review and recommend a limited number of methodologies, specifically for subnational IYCF assessments, like as preferred methodologies for the emergencies and humanitarian contexts. And for us, SMART team, to consider facilitating the integration of an IYCF, standardized IYCF module in the new SMART Plus software that we're working on, that could be used when the IYCF assessments are both done either independently or as a standalone or as part of SMART surveys. In terms of the recommendation number 2, and for the threshold, IYCF thresholds generally are not very much available, but the GMC did work on the humanitarian needs analysis tool, and they developed it, and that provides an opportunity to recommend this kind of consensus-driven threshold. So for specifically the recommendation for threshold, we do recommend to use them as an interim and review the progress and the experience of utilizing those thresholds when conducting IYCF assessments. Next, please. Finally, on behalf of ACF Canada, the SMART team, I want to acknowledge and thank the following partners who made this mapping exercise possible. Save the Children, GNCTA, INS, NIS Working Group, the IFE Core Group, and all the colleagues that kindly responded to our survey. Thanks a lot. I think I'll give it back to you, Linda.
Thank you so much, Jana, for your excellent overview of the IYCF-E assessment mapping exercise. I am sure there will be a lot of questions for Jana to respond to, so please put your questions in the chat box or in the Q&A. Colleagues, I am pleased to introduce our panelists for today's moderated session on the new UNICEF WHO IYCF indicators. Colleagues, in no particular order, I have Lawrence Grummer-Strong, who is the unit head of the Food and Nutrition Actions in health systems at WHO. He coordinates WHO's work on infant and young child nutrition, treatment of acute malnutrition, and the prevention of micronutrient deficiencies. Until December 2014, Larry has served as the Chief of Nutrition Branch at the U.S. Centers for Disease Control and Prevention, the CDC, where he worked for over 23 years in reproductive health and nutrition. Larry has earned his PhD from Princeton University, and he is an epidemiologist who has authored over 180 scientific publications. He is also a key author of the UNICEF WHO IYCF Indicators. With us today also is Brenda Mera, who is a physician and a public health professional with expertise in data analysis and monitoring of child nutrition. Brenda is a statistics specialist with the Division of Data Analytics, Planning and Monitoring at UNICEF. And Brenda has led the development, expansion, and maintenance of UNICEF's global databases on infant and young child feeding, and contributed to the methodological work in this area, including the updated guidance on IYCF indicators. Before UNICEF, Brenda worked with academic universities where she supported the evaluation of maternal, newborn, child health and nutrition projects and published several papers. Also with us today, I am pleased to introduce Dr. Oleg Buleka, who is an Associate Director for Science at the Centers for Disease Control and Prevention, where he has worked since 2000. His advanced expertise includes international nutrition, statistics, epidemiologies, surveys, and surveillance, among other topics. Colleagues, Dr. Oleg has published over 40 peer-reviewed papers and reviewed over 20 scientific journals, including the Lancet, the JAMA, and the BMJ. He is a world expert on nutrition assessment methods in emergencies and post-emergencies, as well as an active member of the Global Nutrition in Emergencies Working Group, where he regularly advises senior nutrition technical staff on major international and UN agencies to activate the nutrition sector. Colleagues, it is a great pleasure to have you with us today. Over to you, Linda, and colleagues.
A pleasure indeed. Thank you so much, Fatmata. And now I think it's time for us to engage with our panelists. To give you an idea, we actually prepared a few questions and themes around the IYCF indicators, the recently revised IYCF indicators. And the first question that I'd like to ask to our panelists relate to the prioritization of indicators, and Jana had alluded to some of that. And the question goes is that there's a consensus and there's agreement that the new indicators are important to assess in order to provide appropriate and effective IYCF programming. We also understand the rationale for each of the indicators, and guidance for calculating the indicators is understandable. However, especially given that they're no longer core and optional indicators, the difficulty is really in how to prioritize these indicators, especially when there are scarce resources, when there are donor requirements, and multi-sectoral projects that do not allow for the use of all the indicators. Specifically in emergencies, nutrition may be a small component of a larger response. And again, we saw some examples from Jana's presentation. However, IYCF surveys may be more intensive and may require more resources. Therefore, we have a few specific questions. Which indicators would you say should be a priority to integrate in, for example, smart surveys? How can we integrate these new indicators into multi-sector surveys? what would be priority indicators for different contexts, including conflict settings, and which ones would be priority to integrate if it's not feasible to integrate all. So it's really around using these indicators and prioritizing them for different surveys and contexts. Therefore, I address this question to all three of our panelists, and may I first maybe ask Brenda to address this question.
Sure. Thanks, Linda, and hello, everyone. Yes, it's true that we have no longer got the distinction between core and optional indicators, but essentially, I would take the first question around which indicators would be a priority to integrate in, for example, the SMART surveys. So for our global databases, we review a lot of different data sources, including SMART surveys, and our review has indicated that increasingly SMART surveys have been including the standardized questionnaire that was published in the 2008 indicator guidance document, which was the earlier version of this updated indicator guidance document. And although the number of questions in this updated version has increased from this 2008 version, the new questions basically are needed for the calculation of two new indicators on unhealthy eating practices, which is sweet beverage consumption and unhealthy food consumption. All the other 15 indicators that are recommended in this updated guidance can actually be calculated based on questions that have already been used in survey programs for a long time. So, for example, to put all of this in context, initially, percentage of children ever breastfed was an optional indicator. So although it was an optional indicator, that question has always been asked in IYCF surveys because it is needed to determine the percentage who are put to the breast within the first hour of life, which is early initiation of breastfeeding. So it does not really require asking of a new question or an additional question that has been there. I think I would stop, at least for now, on the first question and see if others have anything to input.
Thank you, Brenda. May I ask Larry to see if you would like to input on this question?
Sure, Linda, thank you very much, and good to be with you all today. So I would definitely echo what Brenda said, that the new indicators really aren't that much greater than they were before. The number of indicators is greater, but the actual data collection is not that different than it was before. And that actually reflects some of the reason why we moved away from having core and optional indicators. It gave the impression that these optional indicators were less important, and yet they actually weren't any harder to collect. And we said, you know, if you're already collecting the data, why wouldn't you look at the data in multiple ways? And so most of this proliferation of additional indicators does not reflect any new data collection, except as Brenda said, on the sugar sweetened beverages and unhealthy foods. So if you were able to do it before, there's really no reason that you couldn't still do most of these indicators. But I do think that it still raises a valid question with the complexities that we have in emergency settings. Is it possible to get adequate sample size and a full questionnaire of doing all of this? So what would we need to give up? In fact, as we saw in the presentation that we just had a few minutes ago, that meaning of core and optional doesn't actually reflect what is done in the field. Some of the optional indicators were more often reflected than many of the core indicators. So people were kind of prioritizing on the basis of what was of interest to them, not in the core versus optional anyway. So we're left with, so what would you do if you had to cut back? If it really is just a matter of this is too long a questionnaire, we can't go through it. I think it's helpful to start thinking about, you know, what's possible to cut away. And the problem that we run into is that you're going to have difficulty with comparability to standard indicators that might be reflected at the national level. If you want to compare to a previous national survey or to another setting, any real change, any substantive change to the questionnaire is going to hurt that comparability. That's a downside, but on the other hand, it also can give you some flexibility in saying, yes, but for our setting, we need different data. We need to be a little bit more targeted in what we're looking at and what we're going to do with those data. So I would look, rather than at what indicators can I drop, I would look at what data is of least interest in my context if I have to cut back. And I think the first place I would start is on the long list of foods. We have many different foods listed there because of the need to get at dietary diversity. We want to look at 8 different kinds of foods there. We want to make sure that we're capturing those. So I would say you may just have to give up, if you can't get the probing, give up on some of that dietary diversity overall and focus in on some key categories of foods that are most important in the population. If you can't do all of it, then I would say I would probably be focusing first on egg and flesh foods. The animal source foods are such a key important ingredient or component for micronutrients. And that is often what is the rate limiting food to keep those from being met. And secondly, fruits and vegetables. So if you had to cut back, that's where I'd say the most questions that you could get without losing most of the indicators would be in that area. So I would start with some of that. The liquids, I think probably could be categorized a little bit more in groups than they are. We do more probing on different kinds of liquids, but they probably could be broken down into smaller sets. Ultimately, I think the most important indicators or way of looking at the data for emergency settings would actually be the area graphs that we create for children less than 6 months of age or infants less than 6 months. And for that, you need to say, are they exclusively breastfed? But if they're not, what is going on? Is it water? Is it other liquids that they're being given? Is it breast milk substitutes? Is it solids? Because those are really what's going to drive your programmatic, where do I need to intervene, that I need to make a change. As you look longer term at the complementary feeding, really I would focus in on the animal source foods and the fruits and vegetables. Of course, any cutback, you're going to be giving up on something. It's always hard when you say prioritize, oh, we don't care about junk foods. Well, still, we still care. But if you have to give up on something, that would be an area that I would be giving up on. I'll stop with that.
Thanks so much, Larry. This is really useful. I'd like to also ask Oleg if you would like to also reflect on that question specifically, maybe the first bit on SMART surveys and priority indicators. Dr. Oleg, I think you are on mute. If you could please unmute.
Can you hear me now?
Yes.
Thank you, and thanks for inviting me to this webinar, and greetings to all the participants. So yes, in SMART surveys, obviously, we are trying to keep the number of questions and the time of the interview to a minimum. So sometime we would actually encourage to choose the questions on IYCF that are most programmatically important. And as a previous speaker mentioned, probably the most time-consuming part of the IYCF questionnaire would be a probing on different types of foods and liquids, both to assess dietary diversity and also to assess this question on infant feeding area graphs, basically, non-milk liquids, milk liquids, breast milk, etc. So definitely we encourage to make the questionnaires setting specific. I would agree that administering the full questionnaire versus administering part of the questionnaire probably would not make much of a difference, but it may be 5 minutes plus, 5 minutes minus. Definitely unhealthy food consumption, snacks, sugar beverages may be less important in very low resource setting, in sub-Saharan Africa, where we have refugees, displaced people. Some questions definitely may seem out of context. on the other hand, in some other refugee populations, for example, like Syrian refugees living in Jordan, in Turkey, in Lebanon, definitely, actually, unhealthy food consumption is an issue, and in those populations, actually, we may see more overweight than underweight, than wasting. So depending on the population, we can definitely choose and discuss with the colleagues what specific indicators are most relevant to specific situations.
Mm-hmm.
Thank you.
Thank you so much. I'll hand over to my colleague Hassan for the next question.
Thank you very much, Linda. Maybe follow-up questions to Dr. Oleg. Are there ongoing efforts by this SMART initiative or other groups, WHO, UNICEF, other UN agencies, to pilot rapid assessment methods of the new indicators that could be accepted by the international community?
Thank you. I'm not aware of new rapid assessment methodologies that are being proposed beyond what we already have. I think these questions are really meant for use in population representative surveys, because like the way these questions are posed, they are intended to generate a population representative prevalences of different behaviors, different types of food intake, etc. And I mean, rapid assessment is a little bit misleading, because some people call SMART surveys rapid assessments. As colleagues mentioned, the question of sample size is also an issue. So we are looking forward maybe to discussing more in detail in this webinar what minimum sample size colleagues are thinking of when they're thinking of generating the prevalences. And actually, what would also be interesting to discuss, we see these IYCF indicators used in many surveys, but unfortunately, so far we have very little to no information on the design effect, whether these behaviors are clustered or these behaviors are fairly uniformly distributed in the populations of interest. And that would also inform a little bit like how big the sample size we need to generate stable, relatively stable prevalences for each of these indicators. So my short answer is these indicators are mostly for representative population surveys. And obviously they are widely used in mixed and DHS surveys. Sample sizes in those surveys are huge and they're absolutely sufficient. Use of these indicators in SMART surveys is more challenging because obviously effective sample sizes for different smaller age group windows in which we are assessing each of these indicators present some challenges to attaining sufficient sample size. Yeah, thank you.
Thank you, Dr. I'm going to hand over to Fatmata.
Thank you so much, Gemma and colleagues. I am going to circle back to Larry and ask this question. Larry, I know you touched on this briefly during your earlier presentation, but this is a question that has been coming up a number of times from colleagues from the field. Because of the narrow age ranges required for the denominators of some of the indicators, as example for caregivers 0 to 5 months, the sample size needed for a statistically significant result for the survey becomes quite unwieldy. And such a large sample will tie up scarce resources during personnel, including personnel that will otherwise be put forward towards essential services. So donors require baseline and inline prevalence, even in short emergency projects, but are typically unwilling to fund such intensive surveys. Already, this is a challenge that existed with the previous indicators. So, Larry, I'm going to ask you to provide us some of your thoughts around how we can balance meeting the needs and measuring the needs, and also whether we could use purposive sampling to consider the breakdown suggested, or even narrower age ranges that will have low meaning, example 2 to 3 months. Larry, this is for you, but I'm also going to open it up after your feedback if any of our colleagues, Brenda or Dr. Oleg, will have additional points to make. Larry, over to you, please.
Okay, thank you, Fatmata. There's so many issues packed into this question. Sampling isn't just a matter of how do we get a sample, but it brings in so many other issues. I think that the main reason that we have framed this around household surveys is that we want representative data. We want to be able to statistically take the results of our survey and say this applies to the entire population. And to do that, we have to have a way of basically knowing what the universe is to draw from. We do household surveys because it's fairly easy to define the universe of households. We know where there are structures, where we can go and talk to people and collect data. But it's not the only way. It seems to be the most efficient way for national surveys, but is it necessarily the best in emergency settings? I do think we have to look at how those settings are set up. If we can find alternative ways to find children less than 2 years of age and be representative, that probably is optimal. It would make it much easier to do the survey and get right to the population that we want to ask these questions of, rather than spending so much time knocking on doors, going through lots of screening questions to get down to that. So if there are other ways, then I think it is perfectly legitimate to do a more purposive sampling on the basis of that kind of universe. So, are there registries of the people living in a refugee camp, and you know where those children are? Are there surveys of where births have occurred over a certain period of time, and you know where those are occurring? I think in most situations, those don't exist, but if they do exist, then you certainly can get representative data. I think what then happens is if you don't have a way of doing that, if there's no way to do a household survey, it's just too costly to get an adequate sample size, and you don't have another way of finding these children, then you're going to have to go to something that is not representative. And the result is that you won't be able to generalize, this is the number for this population at this point in time. That doesn't mean it's useless. What you have to do is you really need to think about why are you collecting these data? And if it's really to get a background that you want to use this for planning your, how should I be providing services? Is this a population that has very high rates of breastfeeding or low rates of breastfeeding? A purposive, non-representative sample is probably good enough. If you're trying to evaluate, are your interventions actually having an impact? And are there certain areas that we should be focusing our attention on? Again, you might be able to work with a different population, maybe those who are coming into a clinic or are appearing for screening for other purposes. Might be a reasonable sample to work from. It's not going to necessarily represent the population. You can't generalize, but it still gives you enough information that you can say, look, I can use this for evaluating, is my program doing what it's supposed to be doing? Are you trying to be doing trends for a comparison to what the population was prior to the emergency to after? Those become much more difficult because you have to really be comparable in your methodology. What I would say is that if you expect this is going to be a situation where you're going to want to do the survey multiple times, as you put in here a baseline and an end line, if there's an expectation that the emergency may be lasting over some time and you're going to want to do this periodically, make sure you come up with a methodology in which you are sampling in a consistent way. It may not be representative, but you may say, look, I'm going to do this in the people who come to the clinic for vaccination. Use that consistently over time, because you will not be able to compare a sample from a vaccination survey in one place and another that was based on an existing household survey that you tagged onto. Mixing methodologies is going to really make a mess of interpretation of your results. What I would say is that you really need to also think about the time frame of what data you're looking for, because while we do these surveys as what's going on at this point in time, we do have to recognize that infant feeding is something that changes over time and is a reflection of what has happened in the past. So if you're coming into an emergency and let's say you're 2 weeks in and you want to get this assessment, your assessment of is breastfeeding continuing in the second year of life primarily is going to be a reflection of what was happening long before the emergency started. You can't say that no one's breastfeeding now because of the emergency. It may be that they had stopped breastfeeding long before. Similarly, exclusive breastfeeding isn't just what's happening today. It's a reflection of, did they start introducing complementary foods earlier? Did they start using water? While families can go back to more exclusive breastfeeding, in general, they don't. In general, it's a progression toward more and more, basically insults, if you want to count it that way, to exclusive breastfeeding. And so if you're already 6 months into the emergency, then yes, it's reflective of what's happening during the time of that emergency. But if you have a much longer time frame in which those behaviors were occurring, don't expect that it's going to be relevant. And therefore, the sampling and which indicators you would focus on are going to be dependent on what's the purpose of it and what kind of time frame you're working from. I'll stop with that for the moment.
Thank you so much, Larry. This is so insightful. I take your point about alternative ways of reaching children under 2 years of age, and also looking at registries, births, and ensuring data is representative where possible, but we can also use purposive sampling, but ensuring the consistency of sampling. That's a really important take-home point for me. But Brenda, do you have any additional points to make on this question?
Thanks, Fatmata. Just one additional point adding on and echoing what Larry just said. I think another way to tackle the small sample sizes that we have for a number of these IYCF indicators is really to have that room of negotiation with donors, that you choose at that time indicators probably with larger sample size, because emergency context, usually they are short-term projects like you mentioned. So it probably makes more sense to maybe select continued breastfeeding or diet indicators like minimum diet diversity, where the sample size is already large enough so that you're able to see some change within a short period of time. Because like we said, the recommended frequency of doing these IYCF surveys is 3 to 5 years, and we don't expect changes that frequently to happen. So also, again, echoing the fact that it ultimately boils down to what the program is trying to change in a short period of time, and then selecting those indicators and then sampling populations based on that. Over.
Thank you so much, Brenda. That's indeed very helpful. So I'm going to hand back to Hassan and Linda for the next set of questions. Thank you, Larry. Thank you, Brenda.
Thank you very much, Fatmata. So I'm just gonna follow up this question to Brenda. And so the list of typical foods and beverages consumed by IYCF needs to be adapted to each context. This may require harmonization between actors conducting such type of surveys in a given country to allow robust comparison. The IYCF working groups may help in some countries. However, visual tools may also be required for field data collection. Are there plans to develop job aid for the indicator guidance, for example, to guide the field enumerators? And do you think this is something that is useful?
Thank you. No, I definitely feel that it is very useful to adapt the beverage and food list and really use visual tools to support data collection, especially when it comes to categorizing the different food items into the different food categories. However, we do not currently have plans to develop job aids specifically, but the guidance document has a section on selecting and training interviewers, which provides examples of undertaking interactive exercises with the interviewers where they are giving some item cards or images with pictures of food items on it, and then they have to sort it and categorize it correctly into the proper food groups. So you could undertake the interactive exercises, do role-playing, classroom practice, field practice with the data collectors just to build on their skills. And it is also helpful if the enumerators are actually trained in nutrition or they have had some background previously in conducting these nutrition surveys. But I would also like to say that in the absence of these job aids or visual aids, there are currently efforts underway just to circle back to adaptation of the liquid and food list, which is currently happening. So at UNICEF, for the UNICEF conducted mixed surveys, we actually provide inputs to the adaptation of the food and the liquid list at the survey design phase when the questionnaires are sent to our sector specialists for review. And additionally, we also know of a project with USAID Advancing Nutrition and the Global Diet Quality Project, which is trying to build a repository of sentinel food groups that are consumed by majority of women and young children across different countries and in different country contexts. So the idea of this particular project is that there would be a standardized list or adapted food list for different countries, which would be available on a publicly available website, and survey programs can actually take that list into future surveys to allow for some harmonization. So I'll stop here for that.
Thank you very much, Brenda, for that. Back to you, Linda.
Thank you, Hassan. And maybe just to ask whether Dr. Oleg or Larry have any additional input on the previous question. Please feel free to, yeah, Dr. Oleg.
I just, from Brinda's actual response, I got an interesting idea, because when the preparation is done for mixed ODHS, it's quite a serious, systematic preparation. And if they go through this exercise to list the foods and to validate the local foods, actually this may then be a useful starting point for the smart surveys done in the same country. I'm not saying that these lists should be used as they are for displaced populations in all the contexts, but actually making these like adapted standard food lists that are done when mixed ODHS is done, making them available then to the agencies that are doing IYCF in smart surveys could be a useful starting point and would probably help them to to collect data in a more or less standard way, so that it's comparable among surveys conducted by different agencies. Over.
Wonderful. Thank you. Thank you for that.
Maybe I'll just add one very brief comment to build on what Vrinda was talking there about the adaptation using the dietary quality data. We were both on a call just last night about some of those data. It was a broader call, but we were talking about some of that. And they pointed out that really a list of only like 5 or 6 foods within each of the lines on the survey seemed to capture about 95% of the consumption that was there. So the need, it needs to be done by country, but using the data that Vrinda was just talking about, they really were finding that you don't have to do a whole lot more probing to capture every food and all of the different nuances that are there. Yes, there will be some error, you will miss some things, but it seemed to be a very small number that might be missed. Obviously, that could be a little bit different in displaced populations if the diet is being skewed. But my guess is that in general, the dietary diversity and what's available in those settings is reduced, not increased. And so you're probably going to be doing even better. Not in every circumstance. There might be some special nuances to the diet. But in general, once those data are publicly available, and it sounds like it will be quite soon, it could make that adaptation process much easier.
Wonderful. Thank you. This is really very useful. And hopefully we'll hear from you also on that bit, some updates as they are out. Thank you. I'll circle back to Brenda, if it's okay, to also ask a specific question related to threshold. And I think I saw a question even in the Q&A on that. We know that within the SPHERE standards that there are thresholds for acute malnutrition indicators we don't have for IYCF. And so are there thresholds that you would recommend to use in emergency context, and what indicators would the thresholds refer to?
Thanks, Linda. So for the emergency context, I'm not sure if thresholds need to be different from the regular context. So definitely for IYCF, and specifically within the IYCF domain of indicators, we do have the Global World Health Assembly targets for exclusive breastfeeding for the year 2025 and 2030, which is to achieve at least 50% exclusive breastfeeding by the year 2025 and 70% by 2030. And this global target may be adapted as thresholds even within the emergency context. For now, this is the only target that's available, but I think in terms of additional indicators, something around minimum diet diversity would also be helpful. At UNICEF, at least, we have started looking into the data and coming up with the various cutoffs and thresholds that would make sense, but that's still work in progress. So I'll stop here for that. Thanks.
Thank you. Great.
Linda,
Yes. Yes.
Could I add a comment on that?
Yeah.
I think that unlike many other of the indicators in SPHERE, this is one where it really doesn't make sense to have a global threshold. I mean, while Brenda is right that we do have a global target of what we'd like to achieve on exclusive breastfeeding, when you look at the country level and what's appropriate for that country and what can be done in a short time frame, for some, it doesn't make sense to talk about 50% because they've already got 70% exclusive breastfeeding. You certainly wouldn't want your target to be to reduce that. And other countries are at 10%. It is just completely impossible to expect that you're going to achieve that in a short, I shouldn't say, it's not impossible, but it's difficult in a short time frame. And I'd say certainly in an emergency situation, particularly difficult. To me, the most valuable threshold would be what has been happening in that population prior to the emergency. And you don't want to fall below that. Don't let the emergency cause your IYCF to worsen. So if there are pre-existing data from the country or from a nearby country that you think is in a comparable situation, that's where I would be starting my threshold, ideally to make some progress on that. But given how wide these range from country to country, like I say, 10% to 80% we get on exclusive breastfeeding. I don't remember on the minimum dietary diversity, but likewise huge ranges. Rather than a single number, base it on something that is much more locally relevant.
Absolutely. Dr. Oleg, would you like to add anything on that?
No, I absolutely agree that, for example, in the US, breastfeeding may be low, but for example, dietary diversity and meal frequency may be absolutely adequate, whereas in some other countries, it may be the other way around. So applying the same threshold to different population doesn't really make much sense. It's really the trend that we are looking for, and for that, like baseline data, previous data is very important. What did this population look like a year ago or in stable situation, and what changes we are seeing now? Do we see deterioration because of the emergency, or do we see improvement because of our great programs? So I would definitely agree with Larry on that.
Thank you. So I also see in the Q&A questions about thresholds for the complementary feeding indicators. And we heard about that from Brenda and you and Larry. Also the importance of, as you're all saying, compare, to look at trend, to look at change before and after, which makes it even more important to have data prior to an emergency and be prepared for that. So all very valuable. Thank you so much. I think I'm now going to hand over to Fatmata for a closing question before we go to the Q&A, because a number of questions are also there from the audience. Thank you.
Thank you, Linda. Indeed, there are a number of questions. So this will be our closing question for the panel, and then we will go to the questions from our participants. So colleagues, Larry, Brenda, and Dr. Oleg, are there any additional actions, efforts that UNICEF, WHO, and CDC and the Nutrition Information System Technical Working Group are planning to support in the adaptation of these indicators in emergency and fragile contexts? So perhaps I will start with Dr. Oleg, and then to Larry, and then Brenda.
Thank you. So several points here. First, these indicators are standardized indicators, so we want as much as possible that these questions are asked in the same way in different surveys, so that we get comparable data. Because if this like the questions are rephrased or changed, then people may be producing or generating these indicators, but the prevalence would not mean the same thing as the prevalence in other surveys. So the first point is to standardize as much as possible what questions are used across all platforms, makes DHS smart. In the new software that we are updating for SMART, we are planning to have these question banks. And obviously, if we have standard questions that people can pick and choose and drop into their surveys, and they are already available in the question bank, that would really facilitate standardization so that people don't invent their own questions. They use standard question from the bank, and it's very handy and easy. Obviously, second is translation. How these questions are translated, what is the quality of translation to make sure that we preserve the meaning. And also, obviously, not all of the questions, but many of the questions, they need special training and role playing, basically. It doesn't just take like 10 minutes in the training to just say, okay, let's read through the questions. Do you have any questions, how to ask them? Really, I think probing for specific foods, understanding what the local foods are, etc. We need to make sure that if we really endeavor to measure these indicators in, for example, smart surveys, that sufficient time is spent on training interviewers how to properly ask these questions, and not just run through these questions assuming that interviewers will be doing a good job. And in terms of like additional actions and efforts, I think that as we build the databases of surveys, and as we have the data aggregator and agencies will be sharing with the central database their data sets, I think we will start doing some research and looking, for example, what is the design effect for these indicators, and that would also inform sample size calculation, and looking what sample sizes people are achieving for IYCF indicators in smart surveys, to then give some guidance, basically, and understand better. Because if we're having only 30 children or 40 children for a specific indicator, that may not be sufficient. And sometimes for anthropometry indicators, it's a standard smart output that we automatically give the confidence intervals. But for IYCF indicators, I've seen reports where they just give the prevalence without confidence intervals. And if obviously these prevalences are only based on 30, 40 children, these prevalences may have very wide confidence intervals to the point that they are unstable and maybe a little bit misleading. Over.
Thank you so much, Dr. Ole, for those intriguing points. I take your point about the importance of standardizing the questions, the translations to maintain the meaning, and then sufficient time spent on training. I will pass it on to Larry for his contributions to this as well. Larry, over to you, please.
Okay, thank you, Fatimata. So to the specific question here, what we're doing on the adaptation in emergency and fragile context, this isn't really an area that WHO is working on actively right now. There are activities that are related in various ways that I think will contribute to this, but nothing that is so specific. We are working on guidelines for the both prevention and treatment of wasting. So it's not for the general population of an emergency setting, but clearly for those children who do slip into moderate or severe acute malnutrition. We'll have further guidance on the feeding, and that may have some implications then about this prioritization. What kinds of indicators would we really want to focus more attention on in that context? More generally about the guidelines and the kind of the application and standardization, we're certainly working more on dissemination of the manual. There are many that have heard about it but don't know much about it, and taking a 200-page document and making it accessible are some of the things that we're working on. There is a WHO UNICEF team, we call it TEAM, that looks at a number of monitoring issues and recommendations for surveys, and a subgroup of that is really focusing in on the IYCF indicators to get them out more widely used and answer questions about them. We're certainly involved in Q&A. Many people reach out to us with specific questions about, well, what should I do in my context for this indicator? How do I measure this differently? What can I do here to adapt this? And so trying to address that. And I think that will probably lead us to a little bit more of a Q&A. We're not ready to write that today, but as we keep hearing these questions coming in frequently, we'll try and get better guidance out to that. We're also working on translation of the questionnaire into the 6 UN languages. And I mentioned this meeting that we had yesterday was with DHS, and that was about cognitive testing of the questionnaire in ways that the questions work well. And we just got some results back on that. So we're looking at, are there some adaptations that might need to be made to the way the questionnaire is done, or at least in how it's applied in different contexts based on how some questions worked well and some questions were a little bit more complicated for the respondents to answer. So it's much more focused on application of the existing guidance across the board rather than specific to emergencies, but hopefully it would be relevant guidance there as well. Thank you.
Thank you so much, Larry. I think those are really important activities to help in the further adaptation of the indicators, including the further dissemination of the manual, the Q&A, and the translation into different languages. Thank you so much. That will be so helpful. Brenda, over to you, please.
Thanks. So just adding on to, Larry has given a very comprehensive overview of the different dissemination activities planned for this guidance. But I think additionally, with this guidance on practice indicators, there are other ways with which we can supplement information specifically in the emergency context. On this front, UNICEF is leading the development of a standardized set of indicators to be collected in emergencies through DHIS2, the Routine Health Information Systems, where we have had a round of consultations with global stakeholders that includes WHO, GNC, IFE. Some of the members and partners have been part of those discussions. And we actually just had a call yesterday And it seems from the partners reporting tool, few additional IYCF indicators are going to be recommended into the DHIS2 emergency module. And we would be sharing that updated guidance as and when it becomes ready. But also at this point in time, we are compiling a list of topic areas which would be pilot tested for DHIS2. And as we collect these areas, we can see what more needs to be done in terms of monitoring this, specifically in the context of emergencies. Over.
Excellent, Brenda. Those are really important additions. Thank you so much. We look forward to the development of the standardized set of indicators through DHIS2 for emergencies and compilation of the list of topic areas and sharing with relevant stakeholders and partners. Thank you so much. I will hand back over to Linda and Hassan for the Q&A session. Thank you.
Thank you very much, Fatmata, and thanks to the panelists for your very, very informative feedback and contributions to these discussions. We have received quite a number of questions, very interesting questions from a very large group of people. We may not be able to answer all the questions or address all the questions during this webinar, but I want to reassure everyone that we will record all the questions and will hopefully provide a written response on the Global Nutrition Cluster Technical Alliance website and as well as the Global Nutrition Cluster website. So I'm just going to pick a sample of these questions and address them to our panelists for feedback. So maybe starting with Brenda, one of our colleagues is asking that they understand that selection of indicators are based on how relevant they are in the context. But do we have a minimum number of indicators that should be done in any survey?
Thanks. It again comes down to prioritization. In our guidance, we feel that all the 17 recommended indicators are actually important, and more so because it does not require additional effort in terms of data collection. But like we said, if in a country or in an emergency context, undernutrition is a problem and not overnutrition, one may think about dropping the unhealthy eating practices. Similarly, when it comes to exclusive breastfeeding for children under 6 months, one really does not have to go through a very extensive list of foods, because we know at that age, you don't need to have all of the different information about the various food groups, but there may be a way to just ask a simplified food group, or just simply ask, did they have any solid, semi-solid food yesterday? So there are ways to still collect that information, but it comes back to something we were saying initially, in that anytime these adaptations are made, there is a risk of losing comparability with the standard recommended indicators. But again, it all boils down to what the program within that context is trying to change, what behaviors they are specifically targeting. So if complementary feeding is not really a target practice that you are trying to change, then you don't have to ask all of those questions, and you can just be focused on the breastfeeding questions for that. So.
Thank you very much for that, Brenda. I don't know if Larry or Dr. Oleg, you have any additional input to that question?
I don't at this point.
Great, thanks. Dr. Oleg? You're on mute, sorry.
I think it should definitely be context specific, and we have to realize that by assessing, for example, one indicator, we're also answering a number of other indicators. For example, assessing food frequency, we're already assessing these other indicators like egg and meat and vegetables, etc. So I don't believe there is a minimum set of indicators. It should be context specific. And I know that often people just kind of put in the whole questionnaire and they, yeah.
Great, thank you very much, Dr. And the next question, I will address it to Larry. So one of our colleagues is asking for a suggestion on how to incorporate these indicators, these IYCF indicators, into routine health information systems of ministries of health.
It's a very challenging question. They weren't really designed for that purpose. They're very much designed for a questionnaire, a household questionnaire. And the expectation is that you have the time where you can go through a structured set of questions with a mother. Most clinical settings don't lend themselves toward that level of detail. Doesn't mean that it's impossible, but oftentimes clinical staff really need to be focusing their attention on the clinical services, not on collecting data. In a numerate population, I think this could certainly be done, or a very literate population, this could be done with a written questionnaire while people are maybe sitting in the waiting room or in waiting lines. But for settings where there's significant illiteracy, I don't think that that's at all feasible. So you really do have to have the personnel associated with it. So I really think that, you know, in a clinical setting, you need to take a very different approach. It probably needs to go at a much smaller set of these, not trying to collect all of the data, but to focus in on some specific behaviors. If you're looking at using that as a setting just to collect data, some of the retrospective questions might be the easiest to ask. When did you start breastfeeding? Was it exclusive in the first 2 days? Not asked that way, but ask the correct questions. But those are quite appropriate to a clinical setting. But they're not necessarily so timely because it might be reflecting for a child, you know, born many months ago. On the other hand, for the clinical practice of treating this child, it's going to be very much dependent on the age of that child. So for a child who is 3 months of age, you're very much going to focus in on just those questions about what is this child consuming at this time. You're not going to do much probing on complementary foods. You might just say, is there anything, any solid foods being given at that point? And that's good enough. So you can boil this down to a much smaller set of questions. On the other hand, for a 22-month-old, you might be very focused on is the child consuming enough meals a day, and what does the overall consumption look like? So I think in that context, you're probably going to have to go to a much smaller set of questions and be much more focused depending on the age of the child.
Thank you very much, Larry, for that answer. Brenda, do you have anything to add to that point?
Yeah, I just wanted to echo what Larry just said, that these indicators are not really meant for being collected in routine health systems. And I wanted to take this opportunity to discuss the findings from our DHIS2 global consultation, where we had country partners. And at that consultation, there was an agreement that IYCF practice indicators, as mentioned in this updated guidance document, should not really be collected through these routine systems because of the challenges that Larry just mentioned, other than early initiation of breastfeeding. So the DHIS2 guidance document that would be coming up next year, you would see that we are proposing to collect early initiation of breastfeeding, perhaps through routine health systems. But other than that, it really focuses on getting information on IYCF counseling and not really any other practice indicators. Over.
Great, thank you very much for that. The next question is related to sample size and sample size calculations. And I'm going to ask Dr. Oleg to respond to this, and maybe just at the same time have the opportunity to maybe get your input or feedback on the earlier question on sampling and sample size calculation. So one of our colleagues is asking, do you think barrier analysis, I believe this is a method for IYCF that has a sample of about 45 doers versus 45 non-doers can be considered as statistical and representative and useful for decision making?
I'm not familiar with this method. I'm sorry. I'm not familiar with with the barrier analysis where you have doers and non-doers.
Right, but maybe just to speak a bit more on the sampling and sample size calculation for IYCF indicators.
Obviously, in smart surveys, we do not calculate sample size based on IYCF indicators. We calculate sample size based on the anthropometry indicators. So if you include IYCF questions into a smart survey, you will have to live with the sample size that you get from that. Obviously, let's say most of these new IYCF indicators are either for 6 to 23 months age window or 0 to 23 age window. So let's say that we have a smart survey of approximately 600 people, 600 children under 5 years of age. Of them, probably approximately like 1/3 will be children, roughly, in that age group under 2 years of age. So I think with like 200, 250 children should be sufficient to achieve sensible, confidence interval. But again, I think we need more data sets to actually look how many children are found in different smart surveys, like how many children we get for different indicators, what confidence intervals we are getting, what design effect is, that's kind of a really interesting question for us. So short answer, in smart surveys, you get what you get from the anthropometry indicator sample size calculation. You don't calculate sample size based on IYCF indicators. If you do a separate IYCF survey, then obviously your sampling will be different. And since it's difficult to find children under 2 years of age, you need to go to more households. As Larry, I believe, mentioned before, it's a little bit more work. So if there are registries, especially in refugee camps where UNHCR is now doing an excellent job and everybody is registered, and at least in the orderly refugee settings, they know where these children live and they can be found. It's really much easier to use the registration data and just say, okay, we only look at the households where we know these children under 2 should be, and we are only going to sample from these households. And we have the registry, and then we'll know the addresses, and we will go to those addresses instead of going door to door to door to door, and only maybe 1 of 5 or 1 of 10 households will have these children. Over.
Great, thank you very much, Dr. Oleg, for that feedback. I don't
Hassan,
know
if I could just add one comment to that. I agree 100% with Oleg that rarely do you make the sample size calculations on the basis of the IYCF indicators. I mean, unless you're doing a targeted survey just for that purpose, which is generally pretty rare. So you're pretty much kind of left with the sample size that you get. Someone else has made a decision for the general purpose of the survey. It's based on other calculations. But I think what's relevant for IYCF is to decide, is it even worth it then to include these questions? If the sample size is going to be so small that you're going to have huge confidence intervals and it's meaningless for you, then why did you waste the time to get a number plus or minus 40%? That's just not helpful. And so I think that it is valuable to rather than take the IYCF questions and build a sample size, is to take the sample size and say, what will the implications of that be for my confidence intervals? And then you need to decide, are those confidence intervals reasonable for my purpose? If my purpose is just to generally understand the population that I'm working in, it might be perfectly fine to have a fairly wide confidence interval. It may not matter if exclusive breastfeeding is 30% or 55%, you know you're somewhere in the middle there. On the other hand, if you're trying to use that for trend purposes and you want to say, is it going up or is it going down? Being in the range of 30 to 55% is not helpful. You're not going to be able to do anything with that information. So why collect the data and then not be able to draw any conclusions from it? Thank you.
Thank you very much for that addition, Larry. And maybe just staying with you, Larry, on the next question. So can we compare nutritional outcomes to changes in dietary diversity?
I assume by that they mean nutritional outcomes in terms of wasting, stunting, overweight, micronutrient deficiencies, is some kind of a biological characteristic. Very difficult to do so. This has been done in some large surveys, and you do see some correlations. The fact is that the indicators that we have are point-in-time indicators, whereas the nutritional outcomes are generally a reflection of a long period of time. And so what a person's diet was yesterday is not a good determinant of what has happened to this person over the last 6 months, 12 months, 2 years. And so it's very messy. And there are also many other indicators going on there in terms of care practices, infections, and many other determinants to consider as well. So I would discourage that kind of analysis. I think there are ways that it can be done in very sophisticated studies to try to tease some of that out, but certainly it's not a direction that I would try to be going in emergencies.
Thank you very much for that. So just a final question maybe to Brenda. One of our colleagues is asking, so in case of emergencies or in emergency context, how are these indicators adapted to populations like pastoralist and agro-pastoralist populations?
Sorry, could you repeat that question?
So in case of emergencies, how are these IYCF indicators adapted to population groups like pastoralists and agro-pastoralists?
Like we said, we haven't done adaptations per se. We haven't really worked on adaptations within emergency contexts or specific population groups. But in general, these are the recommended feeding practices. This is how children in the first 2 years of life should be fed. So in general, it should apply to whatever type of population groups you are looking at. But yeah, like we have been saying, there hasn't been more detailed work into how, for different population groups, some of these indicators or collection methodologies may be adapted. Over.
Great, thank you very much, Brenda, for that. So we're going to stop here for the questions now, but for those questions that were not answered, we will make all efforts to provide a written response, and as I said earlier, they will be posted together with the recording of this webinar on the Global Nutrition Cluster Technical Alliance website. So we're coming to the end of our very interesting and very informative webinar. I want to appreciate again the panelists, Dr. Oleg, Larry, Brenda, for your time and your valuable contributions. So next slide. So we have a webinar sort of evaluation. Please feel free to provide us your feedback, your input on how this webinar was conducted. It would be very useful for us to see how we can improve and be better for the next webinars, or some of the things that actually worked well that can be replicated for the next webinars. Next slide, please. And as usual, if you're looking for support on in nutrition in emergencies, there are a number of avenues that you can ask and receive this support. There is a Global Nutrition Cluster Technical Alliance that can provide and is always available to provide remote or in-country technical support. There is also the Global Nutrition Cluster Technical Alliance consultant roster, where you can apply to be a consultant, or you can also request for consultants through this roster. You can also get technical advice through the Global Nutrition Cluster help desks, and this is support that's available all throughout any day, any time. And of course, through the ENNet platform, you can get peer support and engage with your peers on technical matters. For more of this information, you can visit the Nutrition Cluster website, and you can click on the request for support. And that brings us to the end of our webinar. I'm going to hand over to Linda to do the sort of final closing remarks.
Thank you so much, Hassan. I join you also to really appreciate our really the precious time from our panelists. This has been a really interesting discussion, and I'm sure that we'll receive more questions and more discussions, and I'm looking forward to working together within the IFE Core Group and the NIS and partners on improving IYCF-E, specifically indicators, a lot to do. So hopefully that will be for next year. I take this opportunity to thank the translators and colleagues behind the scene from GNCTA for their continuous support, and wish you a great rest of the day wherever you are joining us from. Thank you.
Thank you.
Thank
Bye-bye.
you. Bye.
Thank you all. Bye-bye.